Arrhythmia. Definition: it's abnormality of the cardiac rhythm or rate. The conducting system of the heart under normal condition. The pacemaker of the heart is the sinoatrial node. The cardiac impulses arises from the sinoatrial node in a rate from 60 to 90 beats per minute. The impulse spreads through the walls of the atria, causing them to contract. Then the impulse reaches the AV node, in which there is delay of conduction to allow the atria to contract before the ventricles. Then the impulse reaches bundle of Hess and the interventricular septum, then along the two bundle branches, right and left. Finally, Purkinje fibers to terminate in the ventricular myocardium, causing ventricular contraction. Sympathetic stimulation leads to increased activity of the sinoatrial node with increased conduction of the AV node, while the parasympathetic inhibits both. Ventricles are supplied by sympathetic only, no parasympathetic supply. Sinoatrial node is considered the pacemaker of the heart because its normal rate from 60 to 90 beats per minute is faster than other cardiac muscle fibers. Sinoatrial node, characterized by its own automaticity, the ability to generate impulses through nerve supply to the heart, aims to regulate heart rate, not to initiate rhythm. Normally, the AV node allows passage of impulses from atria to ventricles, but not the reverse, so there is no retrograde conduction. Clinical classification of arrhythmias: we have regular tachycardia, regular bradycardia, and irregular rhythm. Irregular rhythm includes premature beats, extrasystoles, atrial fibrillation, and type 1 second-degree heart block. Regular tachycardia: sinus tachycardia, atrial flutter, ventricular tachycardia, paroxysmal supraventricular tachycardia. Regular bradycardia includes sinus bradycardia, nodal or junctional rhythm, partial heart block, first degree, and type 2 second-degree heart block, complete heart block, which is third-degree heart block. Then we're gonna discuss the arrhythmia scheme. Etiology of any arrhythmia: for tachyarrhythmia and bradyarrhythmia, we have myocarditis digitalis, congenital rheumatic and ischemic heart diseases, especially myocardial infarction. For tachyarrhythmia, we have sympathomimetics, thyrotoxicosis, and for bradyarrhythmia, we have sympatholytics and hypothyroidism. Exceptions: sinus tachy or bradyarrhythmias, we have physiological and pathological causes. Atrial flutter or atrial fibrillation begins the etiology by mitral stenosis or thyrotoxicosis. Clinical picture: symptoms of tachyarrhythmia: asymptomatic palpitation, onset, offset, duration of the disease. It's short in serious arrhythmias such as ventricular tachycardia and complete heart block. Manifestations of low cardiac output, precipitation of heart failure and angina. Features of the cause: myocardial infarction, rheumatic heart diseases, digitalis toxicity. Symptoms of bradyarrhythmia the same, but there is no precipitation of angina. Exceptions: atrial fibrillation, we add thromboembolism. Ventricular tachycardia, we add sudden death. Complete heart block, we add syncope and sudden death. Signs: we have radial pulse, neck veins, and auscultation. Auscultation: we comment on the first heart sound. It's accentuated in any tachycardia and weak in any bradycardia, with exceptions for atrial fibrillation, ventricular tachycardia, and complete heart block. We have variable S1, nodal rhythm. We have accentuated S1 in spite of bradycardia, and this is the only exception in any bradycardia with accentuated S1. Then we have the neck veins, test for atria, rapid A wave in atrial tachyarrhythmias, loss of A wave in atrial fibrillation, canon A wave in any arrhythmia containing nodal word, whether paroxysmal nodal tachycardia or nodal rhythm. Then we have occasional canon wave in ventricular tachycardia and complete heart block due to atrioventricular dissociation. Canon A wave means severe increase in the right atrial pressure due to ventricular contraction during atrial contraction. The radial parts: we comment on rate, rhythm, response to carotid sinus massage in tachycardia, response to atropine in bradycardia, respiratory sinus arrhythmia. So, rate: increased in tachy, uncountable pulse, reduced in bradyarrhythmias. Rhythm: all are regular except for atrial fibrillation and extrasystoles. Response to carotid sinus massage in tachycardia, reduced heart rate in any tachyarrhythmia except arrhythmias that originate from the ventricles, because ventricles have no parasympathetic supply. In bradyarrhythmia, we comment on response to atropine instead of carotid sinus massage. Respiratory sinus arrhythmia is negative in all arrhythmias except for sinus, tachy, and bradyarrhythmias. It's negative in any arrhythmia except arrhythmia containing the word sinus. This is the other way. Respiratory sinus arrhythmia Inspiration leads to increased venous return, stimulation of sinoatrial node, and increased heart rate. This is a physiological process indicating that the pacemaker is a sinoatrial node. Then we have investigations. ECG, P wave is normal in sinus arrhythmias, abnormal in any other atrial arrhythmias, flutter wave in atrial flutter, fibrillation waves or even absent P waves in atrial fibrillation. PR interval, it represents the passage of impulse from atria to ventricles, short in tachycardia, prolonged in bradycardia, AV dissociation in ventricular tachycardia and complete heart block. QRS complex represents the ventricular contraction, regular except in atrial fibrillation and extrasystole, deformed or bizarre in ventricular tachycardia and complete heart block. Investigations for the cause: echo, congenital or valvular heart diseases, thyroid function tests, and then treatment we're gonna see it later. Sinus tachycardia, definition: condition in which sinoatrial node discharges impulses faster than normal, more than 100 beats per minute, but less than 160 beats per minute. Etiology: physiological, exercise, emotions, excessive coffee. Pathological: hypotension, hyperdynamic circulation, hyperthermia, and heart failure. Pharmacological: adrenaline and atropine. Clinical picture: symptoms, same as scheme. Onset and offset is regular. Duration of the disease is usually long as the condition is mostly physiological. Signs: radial pulse, more than 100 and less than 160 beats per minute. Rhythm, regular. Response to carotid sinus massage, gradual decrease of heart rate. Respiratory sinus arrhythmia, positive. Neck veins, normal, rapid waves. Auscultation, accentuated S1. ECG, regular. Rhythm, rate from 100 to 160 beats per minute. P waves, normal, and each P wave is followed by normal QRS. Treatment of the cause. Usually we need beta blockers and sedatives. Paroxysmal supraventricular tachycardia, paroxysmal condition in which there is an abnormal focus in the atrium other than the sinoatrial node, discharging regular impulses more than the sinoatrial node from 150 to 250 beats per minute. This abnormal focus may be initiated in any area in the atria, paroxysmal atrial tachycardia, or in the AV node, leading to paroxysmal nodal tachycardia. Etiology: physiological, excessive coffee. Smoking. Pathological, same as scheme. Clinical picture: in between the attacks, heart is normal. Symptoms, same as scheme. Sudden onset and offset. Duration of the disease, usually long. History, as a condition mostly physiological. Duration of the attack, variable, usually few minutes, but it may last for hours. Paroxysmal supraventricular tachycardia. If it lasts for more than 50% of the day, it's considered permanent. Signs: during the attack, radial pulse, rate from 150 to 250 beats per minute, uncountable. Rhythm, regular. Response to carotid massage, sudden decrease in heart rate. Respiratory sinus arrhythmia, negative because sinoatrial node is not the pacemaker. Neck veins. Atrial tachycardia, we have normal rapid waves, while in nodal tachycardia we have canon A waves. Auscultation, accentuated S1. ECG, P wave in atrial tachycardia is deformed, while the P waves in nodal tachycardia is absent or inverted. QRS, rapid, regular, with normal shape. Treatment during the attack: vagal stimulation by carotid sinus massage or pressure on eyeballs. Drugs, we have adenosine, beta blockers, calcium channel blockers, verapamil, and digitalis IV. If there is no response or if the patient is hemodynamically unstable, we use DC cardioversion. Atrial flutter, definition: condition in which there is an abnormal focus in the atrium, discharging rapid, regular impulses from 250 to 350 beats per minute, but due to physiological block of AV node, not all atrial impulses are conducted to the ventricles. Only half or third or even quarter of the atrial impulses will pass to the ventricles. Etiology: doesn't occur in normal heart, the same as scheme, but begin with mitral stenosis and cytotoxicosis. Clinical picture: symptoms, the same as scheme, sudden onset and offset. Duration of the disease is short because it's a transient phase between normal sinus rhythm and atrial fibrillation. Signs: radial pulse, variable rate according to the degree of AV node conduction, 150, 175 beats per minute. Regular rhythm. Response to carotid massage, decrease in heart rate but in mathematical pattern due to decreased AV conduction from 2 to 1 to 3 to 1 to 4 to 1, so heart rate decreases from 150 to 100 to 75 beats per minute. Respiratory sinus arrhythmia, negative, because SA node is not the pacemaker. Neck veins, number of A waves is double, triple, or even quadruple the pulse rate according to the degree of AV node conduction. Auscultation, accentuated S1. ECG, sawtooth appearance, P waves abnormal replaced by multiple small flutter F waves before each QRS. QRS, normal, regular, rate half or third or even quarter of the atrial rate according to the AV node conduction. Treatment, drugs to control ventricular rate, decrease AV node conduction, beta blockers, calcium channel blocker, verapamil or digitalis. DC, cardioversion if the patient is hemodynamically unstable. And then we have ventricular tachycardia, paroxysmal condition in which there is abnormal focus in the ventricle, discharging impulses more than SA node, which is 150 to 250 beats per minute. Since the focus in the ventricle, there is no retrograde conduction in the AV node, so ventricles will follow the ectopic focus and atria will follow the SA node, so we will have AV dissociation. Etiology occurs in patient with established heart disease. The most common cause is ischemic heart diseases, myocardial infarction. Other causes, same as scheme. Clinical picture, symptoms, same as scheme. Sudden onset and offset, duration of the disease, short. History, because it's a serious condition. During attack, sustained and non-sustained. Sustained, more than 30 seconds in hemodynamically unstable. Non-sustained, less than 30 seconds. Sudden death if converted to ventricular fibrillation. Signs, radial pulse rate from 150 to 250 beats per minute, uncountable, regular red, negative respiratory sinus arrhythmia, and no effect for carotid massage, no parasympathetic supply to ventricles. Neck veins, normal A wave with occasional canon A waves because of the dissociation between atria and ventricles, so they may contract together at the same time. Auscultation, variable S1, occasionally canon sounds. ECG, QRS, rapid, regular, and wide abnormal, bizarre shaped. P waves, normal rate and shape, may come before or after the QRS or may be hidden by the QRS, so there is no fixed relation between P waves and QRS complexes due to the dissociation. Any wide QRS complex tachycardia in any patient with primary heart disease is considered and treated as ventricular tachycardia until proved otherwise. Treatment. During the attack, if the patient is hemodynamically unstable, immediate cardioversion starting at 100 joules and repeating if needed, adding 100 joules to each successive shock. If the patient is hemodynamically stable, we give amiodarone IV 150 mg IV over 10 minutes and then followed by 1 mg per minute infusion for 6 hours. Lidocaine IV, but recently amiodarone is replaced by lidocaine as the anti-arrhythmic drug of choice for terminating ventricular tachycardia. Adenosine is not effective in ventricular tachycardia. In between attacks, we give LB, and I'm not responsible for this mnemonic. A, amiodarone, L, lidocaine, B, beta blockers, I, implantable cardioverter, defibrillator, or ICD in resistant cases. And finally, we have something called torsade de poids, which is multifocal ventricular tachycardia characterized by QRS complexes. Change in amplitude appear to be twisting around the isoelectric line of the ECG associated with prolonged QT interval. It can be precipitated by antiarrhythmic drugs, electrolyte disorders, hypokalemia, hypomagnesemia, hypocalcemia. Treatment, magnesium and ventricular pacing may be needed. Then we have bradycardia, sinus bradycardia, condition in which the SA node discharges impulses by rate less than 60 beats per minute, physiological during sleep or in sportsmen, pathological obstructive jaundice, hypothyroidism, pharmacological beta blockers, calcium channel blockers, digitalis. Clinical picture, symptoms usually asymptomatic but the same as scheme, and there's no precipitation of angina. Onset and offset gradual. Duration of the disease usually long because the condition is mostly physiological. Signs, we have weak S1, slow normal shape waves in neck veins, and for radial pulse less than 60 for the rate, regular rhythm. Response to exercise or atropine, gradual increase in heart rate with positive respiratory sinus arrhythmia. ECG, regular rhythm, rate less than 60 beats, P waves normal, each P wave is followed by normal QRS, treatment of the cause, atropine may be needed, artificial pacemaker may be needed in severe chronic cases or when sinus bradycardia is a part of sick sinus syndrome. Nodal junctional rhythm, condition in which the heart is controlled by the AV node, impulses reach atria and ventricles at the same time. Etiology, same as scheme, the most common causes are digitalis and myocardial infarction. Clinical picture, symptoms, same as scheme, sudden onset and offset, duration of the disease usually short, history except if congenital, radial pulse slow from 40 to 50 beats per minute, regular rhythm, response to exercise or atropine gradual increase in heart rate, respiratory sinus arrhythmia negative, neck veins, canon A waves, auscultation accentuated S1, and this is the only exception in bradyarrhythmias, P wave inverted and can come approximately at the same time with QRS, so it may be absent. QRS, slow, regular with normal shape, treatment of the cause, atropine, artificial pacemaker may be needed in severe cases. Then we have heart block types, AV block, failure of impulse to conduct between atria and ventricles, sinoatrial block, failure of impulse to conduct between SA node and the atria, bundle branch block, whether left or right bundles. Atrioventricular block is divided into first, second, and third degree. First degree, just delayed conduction. PR interval is longer than 0.2 seconds or more than 5 small squares. All impulses from SA node are conducted to the ventricles. Etiology, physiologically during sleep or pathologically as in myocarditis, usually asymptomatic. Second degree heart block. In this condition, some impulses from atria don't reach ventricles and this causes dropped beats. So we have two types, type 1 and type 2. Type 1, second degree, or Mopeds 1, or Winkbach block. It's progressive prolongation of PR interval until one QRS complex or more are dropped. Then the cycle is repeated. This condition is not so serious and may occur physiologically during sleep or in sportsmen. Type 2, or Mopeds 2, the AV node transmits one impulse for each 2 or 3 or 4 or more atrial impulses. This block may be fixed 2-to-1 all the time, for example, or variable irregular. Complete heart block or third degree. In this condition, all impulses from the atria don't reach ventricles, so the ventricle will be controlled by idioventricular rhythm. Idioventricular rhythm may originate anywhere from AV node to bundle branches or Purkinje fibers. The closer to the origin of AV node, the faster the rate will be. Etiology, same as scheme, plus idiopathic fibrosis of the AV node. Clinical picture, same as scheme, with sudden death and syncope, something called Adams-Stokes attacks. Signs, radial pulse, rate 30 to 40 beats per minute, rhythm regular, response to atropine negative, ventricular escape phenomenon, respiratory sinus arrhythmia negative, neck veins normal with occasional canon A waves, auscultation variable S1 with occasional sounds, ECG slow, regular, wide abnormal bizarre shaped QRS, P waves normal rate and shape, no fixed relation between P waves and QRS complexes due to atrioventricular dissociation. Treatment of the cause, atropine, artificial pacemaker is the treatment of choice. Sinus bradycardia is the same as sinus tachycardia but slow. Nodal rhythm is the same as paroxysmal nodal tachycardia but slow. Complete heart block is the same as ventricular tachycardia but slow. Atrial fibrillation. It's a condition in which there is rapid irregular impulses 400 to 600 beats per minute arising from atria by multiple ectopic foci, so the atria don't contract effectively due to physiological delay at the AV node. Not all impulses are conducted to the ventricles. Etiology, mitral stenosis and cyrotoxicosis, constrictive pericarditis, cardiac surgery, lone AF, idiopathic, especially in elderly, other causes such as scheme. Clinical picture, symptoms, the same as scheme, palpitation, rapid, irregular, and may be paroxysmal or sustained. Duration of the disease may be long. The patients may accommodate for a new rhythm and palpitation disappears. Thromboembolism. Ineffective atrial contraction predisposes to stasis of the blood and may lead to thrombosis with systemic emboli leading to hemiplegia, for example. Signs: radial pulse rate, usually rapid, 100 to 150 beats per minute, may be slow as in patients on digitalis. Rhythm: pulse deficit, apical pulse to radial pulse, the difference is more than 10 beats per minute. Marked irregularity, you can't count 4 successive regular beats. Response to carotid massage may reduce heart rate due to decreased AV conduction. Respiratory sinus arrhythmia is negative. If the radial pulse becomes regular and slow in AF, then complete heart block is suspected, while if the radial pulse becomes regular and rapid in AF, ventricular tachycardia should be suspected. Neck veins, absent A wave, auscultation variable S1, ECG, normal shape but irregular in rhythm QRS complexes with absent P waves replaced by fibrillation or F waves. Treatment: we have acute management of AF. It involves 3 strategies. The first one, prevention of thromboembolism by warfarin or aspirin, controlling ventricular rate by beta blockers, calcium channel blockers, or digitalis, and finally reversion to normal sinus rhythm. But it's not required in all cases. Methods: electrical cardioversion, drugs, quinidine, fascinide, propafenone, amiodarone. Indications: recent onset atrial fibrillation, no history of recent embolism, no significant left atrial enlargement. Precautions: discontinuation of digitalis before electrical cardioversion is a must. Anticoagulants must be given at least 2 weeks before reversion to decrease the risk of embolization. And in some cases, as we previously mentioned, it's better to treat by anticoagulant therapy as well as controlling the ventricular rate. Premature beats or extrasystole. Definition: ectopic impulses arising from atria, AV node, or ventricles before the expected next beat, causing what's called premature beat, and it occurs during a relative refractory period. Physiological: emotions, smoking, excessive coffee. Pathological: same as keen. Clinical picture: asymptomatic in most cases with occasional irregular palpitation. Signs: radial pulse. Response to exercise: irregularity disappears due to decrease in diastolic period. Occasional irregularity in rhythm with pulse deficit less than 10 beats per minute. Rate: normal, tachy or bradycardia. Neck veins: normal wave with occasional irregularity. Auscultation: normal sounds with occasional irregularity. ECG: ventricular premature beats are wide bizarre QRS, not preceded by P wave and followed by compensatory pause. Treatment: reassurance, treatment of the cause. In chronic stable cases, amiodarone, beta blockers, calcium channel blockers, or quinidine. Lidocaine IV in emergency cases. We have Wolff, Parkinson, White syndrome, WPW, accessory pathway connecting atria and ventricles which can bypass AV node. So AF is very dangerous arrhythmia in those patients because it can lead to ventricular fibrillation. It's associated with cytotoxicosis, mitral valve prolapse, hypertrophic cardiomyopathy, and they are more common in men. Treatment: amiodarone, beta blocker, radiofrequency ablation is the treatment of choice. Digitalis and verapamil should be avoided because they increase conduction through the accessory pathway. Treatment for arrhythmia in general: we have pharmacological antiarrhythmic drugs, class 1, 2, 3, 4, and others. Class 1, sodium channel blockers. We have class 1A, quinidine and procainamide, broad spectrum. Class 1B, lidocaine, phenytoin for ventricular arrhythmias. Class 1C, flacinide and propafenone, broad spectrum. Class 2 beta blockers, propranolol, atenolol, esmolol for tachyarrhythmias and premature beats. Class 3 potassium channel blockers, amiodarone and brutalium, broad spectrum. Class 4 calcium channel blockers, verapamil, diltiazem for atrial tachyarrhythmias. Others: adenosine, digitalis, reducing automaticity and conductivity. Adenosine for paroxysmal supraventricular tachycardia, while digitalis is for atrial tachyarrhythmias. Side effects of antiarrhythmic drugs: proarrhythmias, new arrhythmias induced by the drug, Quinidine, allergy, hypotension, synchronism, headache, vomiting, tinnitus, blurring of vision, digitalis toxicity, lidocaine, mental confusion, muscle twitching, myocardial depression, amiodarone. Due to its tendency to accumulate in body tissue, it may lead to skin pigmentation, constipation, elevation of hepatic enzymes, pulmonary fibrosis, thyroid dysfunction, corneal deposits, and dizziness, depression, tremors, and CNS. Non-pharmacological non-pharmacological treatment: DC cardioversion, implantable cardioverter defibrillator (ICD), radiofrequency catheter ablation with artificial pacemaker, temporary or permanent. Cardiac arrest definition: sudden and complete loss of cardiac function, usually diagnosed clinically by the absence of a pulse with diminished responsiveness. Without immediate intervention, it will almost always lead to death. Causes: 70% of sudden causes have been attributed to coronary heart diseases. We have two types, shockable and non-shockable. Shockable, they respond to defibrillation, while the non-shockable, they don't respond to defibrillation. Shockable type: ventricular fibrillation and pulseless ventricular tachycardia. Ventricular fibrillation, the most common cause of cardiac arrest, rapid, irregular, uncoordinated contraction without cardiac output. It causes irreversible brain damage after 4 minutes. Pulseless ventricular tachycardia, wide, complex, regular tachycardia associated without cardiac output. Non-shockable, the prognosis is less favorable than the shockable, defibrillation not indicated. We have ventricular asystole and pulseless electrical activity. Ventricular asystole, no electrical activity in the ventricles due to failure of the conducting system of the heart or massive myocardial infarction. Pulseless electrical activity, electromechanical dissociation, no effective cardiac output despite presence of normal electrical activity. This may be caused by tension pneumothorax, massive pulmonary embolism, or myocardial rupture. Precipitating factors of cardiac arrest: we have hypovolemia, hypoxia, hydrogen ions, acidosis, hyper or hypokalemia, but hyper is more common, hypothermia, thrombosis, coronary, pulmonary, toxins, carbon monoxide, cyanide, cardiac tamponade, tension pneumothorax, traumatic cardiac arrest. Management of cardiac arrest: BLS and ACLS, basic life support and advanced cardiac life support. Adult basic life support, 3 components, ABC. Its aim is to maintain circulation until more definitive treatment with advanced life support can be given. Airway, open airway, head tilt if no spine injury, chin lift, maintain clean and clear airways, tracheal intubation. This is considered a component of advanced life support. It's the preferred method to maintain patent airway in unconscious patient with cardiac arrest. Before intubation, oropharyngeal airway, S-shaped device passed over the tongue into the pharynx, can be used to keep the flaccid tongue from falling back and obstructing the oropharynx. Breathing: use specialized bag and mask system or mouth-to-mouth breathing. Avoid hyperventilation by increasing positive intrathoracic pressure, leading to decreased ventricular filling and decreased coronary perfusion, and this can be achieved by using lung inflation rates above 10 breaths per minute. Circulation: chest compressions or cardiac thump, 15 compressions to 2 breaths, performed by placing the heel of dominant hand on the lower half of the sternum with the non-dominant hand on top. Both arms are kept straight. Sternum should be depressed 5 cm inwards and should be allowed to recoil completely before the next compression. The recommended rate of compression is at least 100 per minute. Advanced cardiac life support includes more specific interventions such as airway intubation, mechanical ventilation, defibrillation, and drugs given during cardiac arrest. Defibrillation, direct current cardioversion, is the single most effective resuscitative method for improving survival in shockable cardiac arrest. The recommended energy level for the first shock is 200 joules for biphasic shocks and 360 joules for monophasic shocks. If the first shock is ineffective, 2 additional shocks can be done, and in between perform CPR. Drugs administration during CPR: vasopressors, epinephrine, 1 mg IV repeated every 5 minutes, used in all cardiac arrest. vasopressin 40 units IV as a single dose, dopamine in cases with cardiogenic shock, atropine 1 mg first dose, repeated every 5 minutes, used in cases with bradycardia, or in addition to vasopressors for asystole. Antiarrhythmic drugs according to the type of arrhythmia: amiodarone 300 mg IV, lidocaine 1 mg per kilo IV. Calcium not indicated for all cases in cardiac arrest, but it's indicated in severe hypocalcemia. Post-resuscitation care: 2/3 die because of neurological injuries. Strict glycemic control to avoid hyper and hypoglycemia. And therapeutic hypothermia, mild hypothermia, is neuroprotective, improving the outcome. The target body temperature is 32 to 34 degrees Celsius for no less than 12 hours and not more than 24 hours. And this concludes our part for today.